First lecture, I invite Professor Vladimir Milivojevic from the University of Belgrade, Serbia, to present his presentation, MAFLD, Nutrition and Microbiota, Bidirectional Link. Please, Professor Milivojevic.
Thank you. Thank you, Ludovico, for a nice call. Thank you, Hepatoma Research, for this tremendous event. Thanks to Ada and Victoria for good organization. Thanks all speakers, and I hope so that we will perform that webinars frequently, because this is a very important topic. I choose this topic because it's maybe when we speak about MAFLD and NAFLD, it's for me is the most important discuss about microbiota and about nutrition, about diet. Next slide, please. I'm Vladimir Milivojevic from the Clinical Center of Serbia. Next. In the agenda, I will speak about paradigm shift, about new definition of MAFLD, diagnosis and theology, microbiota and microbiome composition and diversity, and the impact to the MAFLD and liver, dysbiosis, which factors can trigger that, nutritional dysbiosis, and gut-liver axis in the key pathogenesis points. Also, I will mention some treatment options, new treatment options for treatment of MAFLD. As you know, we recently make a new name for NAFLD to MAFLD, and a lot of us here were included in experts around more of 130 countries to reorganize name and to endorse changing of name to metabolic dysfunction associated fatty liver disease. For me, this is very important step, and this is a very appropriate new name for this entity. As you know, hepatic steatosis, when we find out and when we see that detect either by liver biopsy or imaging techniques or with non-invasive tests like blood biomarkers, steatosis. If we have obese or overweight patient, and if we have diabetes mellitus, patients with diabetes mellitus, we can immediately establish diagnosis of MAFLD. Between a normal white patient, hepatic steatosis together with two of that presenting factors which were included in previous NAFLD diagnostic steps can be enough to establish diagnosis. What is the better performance of MAFLD in relation with NAFLD? Because with MAFLD we can have also a dual etiology of fatty liver disease. We can see autoimmunity like etiology. We can see hepatitis like etiology. We can see another factors which are included, which can be in relation with our diagnosis in our patient. That etiology can lead to progression of steatosis and fibrosis. Fibrosis is point of no return. And for us, for clinicians, it's very important to recognize that problem on the beginning and to manage this problem and to make some possibilities to prevent cirrhosis and hepatocellular carcinoma. Nowadays, we can see that with westernization of diet and with more prevalence of obesity, we can find a very, very important factor of liver cirrhosis from the steatosis and from MAFLD. It's a very important thing is to targeting that group of patients and to possible to cure that patients on the beginning and in the good phase. Next slide, please. It's very important to distinguish terms microbiomes and microbiota. Microbiota are all the organisms, microorganisms, which is included in our body, in the gut, and the bacteria, protists, algae, fungi, viruses. Microbiomes is genetic materials which is produced, which is from that microorganisms. And like Hippocrates said, all diseases begin in the gut. Maybe nowadays we are the closest to say that is very, very big too. And as you know, gut microbiota compositions varies depending of part of our next slide depends of part of our part of gut. And in the stomach, we have a little bit sterile environment with lactobacilli, streptococci, some candida, and in some cases Helicobacter pylori. But small intestine and large intestine are richful and with bigger diversity and with much more species, which is lactobacillus, coliform bacteria, streptococci, bacteroides, bifidobacteria, fusobacteria, and various clostridias. When we are going from mouth to rectum, we are changing our pH gradient. Also, we are changing composition, and we have much more bacterial species across our gut. Next slide. And what make implication for our microbiota? Everything, I can say everything for our birth, pregnancy and infancy, and diet from our mother, diet, gestational diabetes, environmental exposures, antibiotics, drugs, things that we are breastfeeding or we are in artificial formulas of milk formulas, different pharmaceuticals, but age also, infection during our childhood, during the infancy, during the adolescence period, and many more factors which can establish good and potent and well-balanced microbiota, or can be with bad impact on or diversity on our microbiota. Next slide, please. And what happens with dysbiosis in the context of MAFLD? Altered microbiome composition leads to low diversity. That can lead to smaller amount of bacteroides, higher abundance of firmicutes, proteobacteria, and smaller amount of bifidobacterias and erythrosporidia. Low abundance of some bacterial species and high abundance of another species lead to higher level of pro-inflammatory cytokines and leaky gut to higher permeability or intestinal membrane. We are going to establish gut liver axis all lead to damage of our liver with big amount of endotoxins, which can make changes in structure of our liver. Yes, MAFLD and dysbiosis shared triggers. You can see stress, smoking, recurrent infections, susceptibility, genetic susceptibility, aberrant immune system, and nutrition can be together factors which can trigger concomitant dysbiosis and MAFLD. If it's nutrition rich in animal proteins and deficient in dietary fiber, we can establish MAFLD. Also, same factors can manage from eubiosis to dysbiosis establishment, and that two factors are like my title of my presentation said, bidirectional link between liver and gut, between dysbiosis and MAFLD. Next slide, please. And what is make that diversity and that make microbiome fluidity? Composition and diversity of gut microbiome begins to form as early as during intrauterine period. Diversity is largest in early years of life, but somewhere and in somehow we have smaller amount of good bacteria like a bifidobacter, lactobacillus bacteroides, and higher abundance of Coccidicea, Staphylococcus, Enterobacteria. Big studies revealed that dominant influence of extrinsic factors like the nutrition is comparable and is most effective than genetic factors. We now know that microbiome manipulation during the childhood can permanently change microbiota diversity and abundance of good bacteria. Next slide. And what is good manner and good nutrients for our gut? For sure, dietary fiber, lipids, and some parts of carbohydrates. Most important thing for nutrition and for our microbiota are prebiotics like butyrate and propionate, acetate, short chain fatty acids, which can be good nutrition for our good bacteria, for lactobacillus bifidobacteria, and which can lead to better environment for our gut membrane. Next slide. And as you can see, we can be in good balance with healthy nutrition, and our liver will be healthy. If we have imbalance in nutrition, our liver start to be with steatosis. In further course, we establish fibrosis, even cirrhosis. What is a balanced nutrition for our gut and for our liver? For sure, that are natural probiotics, polyphenols, omega-3 acids, glutamine, carotenoids, oligosaccharides, fibers, and L-tryptophan. What is imbalanced nutrition which can lead to higher level of leaky gut and of dysbiosis? For sure, high saturated fats and high fructose. Next slide. And how nutrition is targeting our gut and our liver with glucotoxicity and lipotoxicity. Nutritional factors and animal proteins lead to obesity, to insulin resistance, to increase fatty acid uptake, to lipotoxicity, and to oxidative stress. On the other side, Mediterranean diet can lead to a smaller amount of energy, lead to smaller intake of dietary sugars and fats, higher vegetable proteins, smaller intake of salt, bigger intake of fiber and polyphenols. That can lead to prevention of inflammation, of insulin resistance, and that kind of diet can lead to insulin sensitivity. What is effects on the liver? Impaired glucoregulation leads to inflammation, to triglyceride and cholesterol synthesis, oxidative stress, and to synthesis of many pro-inflammatory cytokines and endotoxins, which can be very dangerous for our gut and our liver. Next slide. And what is about that bi-directional link of nutrition and dysbiosis? As you can see, regular diet is homeostasis, but we can, when we have Western style diet, we have gut inflammation and metabolic syndrome. High fat diet can be protective if we decrease intake of sugar and if we increase intake of omega-3 acids. Nutrition can make local and systemic effects. As you can see, Western type of diet leads to microbial dysbiosis, mucus layer degradation, type 2 diabetes, obesity, chronic heart disease, cardiovascular disease, chronic pulmonary disease. Another side, fiber, indoles, and vitamins prevent obesity, prevent intestinal homeostasis, and intestinal immunity. As you can see, nutrition effects of microbiota composition can be various. Intestinal barrier function is the most important thing. We can regulate our intestinal barrier function and our gut immunity with very balanced and very healthy diet with high amount of fiber and with small amount of fructose and non-saturated fatty acids and animal proteins. Short-term nutritional alteration can transitory change gut microbiome, but long-term nutritional alteration significantly change in gut microbiota. We need to insist to our patients to be with long-term nutritional alteration, to be to reduce constant in the effort to long-term alter nutrition habits. Liver axis dysregulation. Gut microbiota leads to dysbiosis, bacterial overgrowth, decreasing of viral diversity, and decreasing of butyrates. That can lead increased permeability with mucus layer, epithelial barrier dysfunction, gut vascular barrier dysfunction, gut-associated lymphoid tissue pro-inflammation activity, and that all can lead to endotoxemia and to increase activation of pro-inflammatory pathways, endotoxin-dependent activation of hepatic Kupffer cells, increase inflammation of CD4, CD8 T cells, and macrophages. That can lead to steatosis and fibrosis of the liver. Next slide, please. What is leaky gut? Leaky gut is the bigger permeability of our gut membrane and various endotoxins which can go in systemic circulation, which can lead to inflammation, fatty acid oxidation, intestinal permeability, and another, together with epigenetic and environmental factors and genetic susceptibility, can lead to serious danger of our liver. Next slide. And what we can say about short chain fatty acids? They have a controversial role in MAFLD and NASH. Systemic butyrate can lead to insulin sensitivity. Next slide, please. And butyrate is also good nutrition for our bacteria in our gut. Also, it's a good protective factor for enterocytes and colocytes. And the firmicutes bacteroidetes ratio is frequently cited in the scientific literature as a hallmark of and biomarker of dysbiosis. It's very important with butyrate. We can make a very high ratio of that type of bacteria, and with butyrate intake, we can prevent dysbiosis. Next slide. Altered bile acid metabolism is very important things also. TX receptors, it's in lipid homeostasis, also in bile acid homeostasis. And new drugs now, which I will mention later, are target for FX obeticholic acid, and new drugs which in phase 3 of study can be a very, very useful agent to improve lipid metabolism and glucose metabolism and bile acid metabolism, which is very, very important in the pathogenesis of the dysbiosis and leading of MAFLD. Bile acids changes as markers of present and severity of MAFLD and MAFLD. As you can see, it's very important and significantly changes of bile acids in presence of MAFLD and NASH, and that changes are more exaggerated when we have severe MAFLD and MAFLD. Yes, small. Yeah, I spoke about dysbiosis in the large intestine, but it's very important small intestinal bacterial overgrowth and toll-like receptor signaling the patients with non-alcoholic fatty liver disease. That we need to speak about small intestine. Small intestine is very important for pathogenesis of MAFLD, and the bacterial overgrowth in small intestine leads to endotoxemia also and leaky gut and liver injury. Treatment targets for our patients: bile acid, dietary fat, bacterial products, and we have a lot of studies and a lot of suggestions to establish combination therapy to different drugs to establish good goals for our patients. GLP-1 agonist, FX receptor agonists have a promising results. Also, next slide. Mediterranean diet is very important part of that treatment procedure. As you can see, EASL recommendation, clinical practice guideline for the management of non-alcoholic fatty liver disease suggests weight loss reduction up to 10% with Mediterranean diet by energy deficit of 500 calories per day, low fat, low carbs, Mediterranean diet, dietary composition modification, reduced fructose, and reduce with high fibers, high fish, high vegetables, low cholesterol, low sugar, with coffee drinking 2 or 3 cups per day without alcohol consumption. Mediterranean diet is the only approved treatment choice for the MAFLD and MAFLD. For me, it's dilemma, do we need to back to the beginning and be like current clinical trials said, MAFLD patients with one therapy to establish some effects, or in a group of patients we will be without effects or with adverse effects. I think that is very important thing to be with precision therapy, tailored therapy. We need to see novel clinical trials about more personalized therapeutics, which will firstly make stratification of our patients with tailored based on the MAFLD patients' heterogeneity, microbiota phenotype, metabolic phenotype, gene susceptibility. Establishing that kind of therapy can be good and promising for next period and for our success with that patients. Next slide. And finally, I will conclude with some points that MAFLD contributes to raising patients' awareness of NASH. It makes the diagnosis easier, lifting of the NAFLD-related stigma, building networks with other metabolic disease with a high risk of NASH. Microbiota dysbiosis, decreased diversity and gut-liver axis dysregulation are present in patients with MAFLD, may contribute to patient stratification and effective therapy options. Our therapy may contribute to patients' stratification and effective therapy options. Short-term diet changes lead to transitory microbiome perturbation. We need to give our patient long-term diet changes that can lead to less inflammation, to less endotoxemia, to preventing of SIBO, leaky gut, consequently to preventing of liver injury. High MAFLD phenotype heterogeneity, microbiota phenotype heterogeneity at complex gut-liver nutrition interrelationship warrant for a precise tailored therapy aimed at different key points of MAFLD pathogenesis. Thank you for your attention.
Thank you, Professor Milivojevic. Thank you too for your presence from Dubai. You are in this moment in Dubai. I know that
Yes.
your flights on. I wanted to ask you briefly only one question, because after you come back to your country, what do you think about this new definition of MAFLD? This new definition of MAFLD made by thousands of stakeholders worldwide is better or not of MAFLD definition?
Yes. We thanks to Professor Faut also we established new definition. For me, it's very better. It's very important that changing of the name of MAFLD to MAFLD, because this is exactly this name, metabolic associated fatty liver disease. It's a real definition of what happens with our liver and with our patients in that kind of diagnosis. In next time, I will in contact with Professor Faut. We will establish from Serbia's endorsement letter. We wrote that letter, and I need to just send somewhere to establish our endorsement to new definition of MAFLD from our Serbian Society of Hepatology and Serbian other society, which I'm coordinator, which is part of our project Dilemmas and Controversies in Medicine, which you know, and which you were part of that congress last month in the Montenegro.
Thank you.
Thank you so much.